Thank you, Madam Chair. And I think one of the most stunning statistics we've heard is the United States is 5% of the population and 80% of the opioids that are used in the entire world. Dr. Adams, you mentioned you've heard from prescribers who say that prescribing guidelines or best practices are a helpful tool because they empower prescribers to decide not to prescribe opioids when they feel opioids are not the best or safest option for a patient. In your experience, how do we best engage the prescriber community to ensure they are actually adopting existing guidelines or best practices for opioid prescribing?
Thank you for that question, and I'd like to hitch on to the CMS conversation. As you're looking at the questions and changing them in the pay for performance, I would suggest that you incorporate in those looking at hospitals and determining whether or not prescribers are abiding by guidelines. Does the hospital have acute pain prescribing guidelines? Because one of the things the Governor's Task Force has charged us with is developing and propagating acute and chronic pain prescribing guidelines. JCAHO could do that also. And so, to your point, engaging the provider community, making it part of standard practice, both we pay you for and we evaluate you based on how you're responding to this opioid epidemic, and are you prescribing appropriately. Integration of prescription drug monitoring data into routine workflow. Doctors want to do the right thing. We just got to make it easy for them to do the right thing and not have to log into 5 different computers to find out whether or not this patient is prescribing. Prescriber report cards, which give feedback to providers, and also linking overdose deaths back to prescribers. You would not believe how many prescribers we talked to who had no clue that the patient they've been prescribing to died, and died because of the opioids that they prescribed. There's no feedback loop in there. So as we talk about prescription drug monitoring programs, we need to talk about making them easy, meaningful for providers to use, and giving them feedback on a regular basis, because a lot of times they think they're doing the right thing, they just don't know. They really don't know.
Dr. Adams, we both frequently hear about the shortage of addiction treatment providers and behavioral health counselors, especially in the more rural areas of our state.
Absolutely.
So what do you think a state like ours can do to incentivize people to go into these much-needed fields?
Well, I tell you, we're doing a couple of things. We're trying to leverage technology, telehealth and remote presence psychiatry to be able to provide access to folks in rural areas. I think you could provide funding for addiction treatment fellowship programs for primary care providers. There are a lot of docs out there who would like to learn more. They just need the opportunity to learn more. There's a project called Project Echo where docs can interact in a group with other docs in a learning environment while they're participating in addiction and recovery services, providing those for their patients. And then fund hospital-based recovery programs that include wraparound services. What we found in our rural areas, and Senator Donnelly, you know this, is that oftentimes the hospital, and especially now that many physicians are hospital employed, leads all efforts in the community, not just for health, but for public health. And we need to get them engaged in responding to this epidemic in a treatment capacity.
You also mentioned about the VA, and you know, this is of concern to
You're going to get me in trouble, Senator Donnelly.
I'm sorry?
You're going to get me in trouble.
That's one of my jobs. You mentioned that several state VA hospital systems, including ours, do not currently participate in the state prescription drug monitoring programs. I know that progress is being made towards integrating Indiana's VA pharmacies into the INSPECT program that we have in our state. Could you tell us some of the lessons you learned from the process of trying to get Indiana's VA pharmacies to participate in INSPECT that could help other states around the country?
Well, there are security barriers with the VA electronic health record system that's been a barrier. But really, there are other states that have overcome it. So the bottom line is that people do what you mandate that they do. And the federal exemption right now for VAs not to participate means that if someone has an option and it's going to be extra work or extra money to integrate, they're not doing it. That is why Governor Pence, one of the first things we heard at our task force meetings were concerns about the VA not participating in PDMPs. In a lot of communities, the VA is the major source for the pills that are getting out on the streets. And many of the people who are suffering from substance use disorder are veterans, and we just don't have that feedback. The same thing for methadone programs, which are federally regulated and aren't required to report to a prescription drug monitoring program. So it's really just someone being aware, saying, we aren't going to take this anymore. You guys sit down and figure it out. And there are obstacles, but we can overcome those obstacles. Several states have.
Thank you. And Ms. Maxwell, the last question I want to ask right now is, In your role as Inspector General, you talked about a number of issues that you're looking at. Have you been concerned about the number of pills in each prescription? So instead of 4 or 5, that we have 30 or 40 or 50. And that is, in effect, the fallback prescription that comes up. Somebody hurts their shoulder, and 2 or 3 days of pain, they wind up with 30 pills in the prescription. And number one, it's devastating to our communities, but number two, on the Inspector General side, it doesn't seem to make much sense either.
Absolutely. As I mentioned, one of the drivers, we believe, behind the increase that we saw, the 156% increase over the 8 years, was the fact that more beneficiaries were getting opioids, but also that there are more scripts per beneficiary. We believe both of those are the drivers, and that is a concern about whether or not Medicare is paying for drugs that are not, in fact, medically necessary, and if that is in some way fueling the supply of the drugs that go beyond the borders of the Medicare population into the general population and fuel some of this public health crisis.
Thank you. Thank you, Madam Chair. Thank you, Madam Chair. And I know that this is a concern of Senator Collins as well, and we've talked about it. In regards to medical school, Dr. Adams, when we had our roundtable in Indiana, we heard a pretty shocking statistic, and this is not to be negative, but it is just an indication of how this has almost been a forgotten thing. They were talking about over the entire time our doctors were in medical school, they talked about 5 hours about prescribing practices. Is that pretty much what you've come across?
And do you remember the response I gave you? That's much more than what I got.
Right.
I mean, unfortunately,
Yeah.
that's the reality in medical school. And to your point, Madam Chair, about stigma, the problem is that it is awareness. It's largely awareness. I mean, there are many different facets to it, but there's not an awareness at the training level, at the administration level, at the treatment level afterwards, of the severity of this problem. And so I do think that we're having some success, particularly in Indiana, with the task force. We're involving folks from the educational communities in the task force meetings and getting the word out. But there's only so much you can stuff into training, and I think it's to the level now where we have to say, look, guys, you may have to push something else out, but this is killing not only our seniors, but citizens across the country. We need to better educate docs in terms of how to properly prescribe.
Yeah, I teach the medical school classes at Stanford on pain, on opioids, some substance abuse, and others, and they get more than 5, but I would continue to argue they need to get much, much more. The deans have been responsive, and we are incrementally improving it. I think it's going to have to be at some level at the individual medical school level, and how are they influenced in part by board exams. The board exams test their knowledge, and I have to give credit to Dr. Scott Fishman of UC Davis. He recently led a task force for us to go to the USMLE, where we all sat down and they opened up their vault, and we could look at all of the pain questions that they were being asked. And I'm not going to steal his thunder, but I'll tell you he's preparing a paper that I think will be very enlightening at a national level that will outline what we really need to do at the medical student level to better improve pain education, opioid education, and the care of patients with pain. And I just say stay tuned for that paper that should hopefully be released soon.
Dr. McKay, I know you have also worked with NIH. One of the things that I've heard rumblings of is non-opioid-based pain medication research that is going on. Could you fill us in on that a little bit?
Could I ask you to reframe that in the context of non-opioid-based? There's a tremendous amount of interest in non-opioid-based research into pain.
Do you see on the part of whether it's our pharmaceutical companies or researchers that the space that is being occupied by the opioids right now will be in X number of years or X number of time replaced by medications that can be a strong assistant on the pain part,
Yeah.
but without the opioid addiction?
Oh, I certainly hope so. That's one of my dreams. You know, one of the challenges in the NIH budget is that despite 100 million Americans, $500 billion a year, we spend a little over 1% of the NIH budget on pain. only a little over 1%. We have a great opportunity to shift some of that, not a whole lot, but some of that into these type of non-opioid therapies that you're describing, into the mechanisms of pain, and discover new molecules, new treatments, whether they be pharmaceutical or even non-medication, mind-body approaches, physical approaches, that are going to have a huge impact on our population, and we desperately need it because the population is getting older. And as we've already pointed out, it's increasing the amount of pain. So we desperately need more of that funding.
And I would say the patient-centered medical home, which is an initiative that many of you have heard about, and the perioperative surgical home, which is an American Society of Anesthesiologists initiative to care for patients from the time that they decide they need surgery all the way through to recovery, and efforts to integrate behavioral health with all aspects of care will help us as we move down that pathway to providing other alternatives. One of the problems is you reach someone when they're getting ready to go out the door, and you've got one person there, and, okay, I've got to deal with your pain, here's a script. But if you start addressing the factors that are leading into that pain and stop that pain cycle from occurring up front, or limit that pain cycle up front and provide options, talk to the patient. A lot of times we're prescribing pain medications for reasons that have nothing to do with pain. We're prescribing them because of untreated behavioral health and mental health issues that coexist in that patient.
This addiction has been, I'll finish with this, this addiction has been so powerful, so destructive in our town of Austin, in Indiana, where we have 189 HIV cases. The CDC came in and in doing interviews found multi-generational situations where at the same table, the grandmother, the mom, and the daughter were sitting there passing a needle from one to the other because of the power of this. And some of these needles, and the way we wound up with 189 HIV cases, is some of these needles were used over 300 times. And it is almost impossible to not have an outbreak of Hep C and HIV in those cases. To all of you, thank you very much.